Thank you so much, and if I could please ask our panelists to step to the stage. So I will be joined by Dr. Petra Khoury, who is Director of Health and Care Department at the International Federation of Red Cross and Red Crescent Societies, Dr. Micaela Serafini, who is Head of Health at ICRC, Dr. Mukesh Kapila, who is Professor Emeritus at the Global Health and Humanitarian Affairs at the University of Manchester, and Alyoscia D'Onofrio, who is Vice President, Head of Technical Excellence at IRC. Thank you all so much for joining us. Does everyone have a microphone? Okay, great. Thank you. So as Kate mentioned, there's been a rapid increase in conflict and climate-fueled disasters that have put millions of lives in humanitarian settings, and that greatly compromises their health. So we're going to talk about some of the challenges in delivering healthcare in these settings, the failures of the international system, and some of the strategies that organizations are using to reach people in humanitarian settings. Dr. Mukesh, I'm wondering if you can start us out and talk about, in a lot of conflict settings in particular, there's a lack of respect for health systems and protecting health systems. Can you talk about some of the situations where that's currently happening and has happened in recent years?
Well, this is the new norm, I'm afraid. There are about 130 armed conflicts around the world, and from the incomplete reporting we have, there are at least 2,500 attacks on healthcare that we know of, and this is an underestimate. At least 500 health workers, and that's also an underestimate, die each year, and or they are kidnapped, brutalized, raped, and so on. And then on top of that, there are the patients who also are brutalized as well. And the trend is, and certainly in the many decades of being involved in this kind of business, is that once upon a time, health was in the crossfire, but today it is in the crosshairs of the combatants. So in other words, what was once an accident used to happen accidentally. These accidents still happen, but more and more these are now kind of deliberate. And for example, in Tigray's civil war in northern Ethiopia, so in the 2 years, something like 97% of the 1,000 plus health facilities were destroyed or thrashed, looted, with convoys taking the equipment out, and in this case transporting it to Eritrea. And you don't thrash 97% of the health facilities by accident. This is deliberate. And similarly, of course, you've seen in Gaza the pulverization of the territory, and inevitably health facilities are caught up in the middle of that, and right down to the incubators for babies have been destroyed. And talking to some surgeons there, a friend of mine was saying that what he found useful was to go back to old manuals from ancient times to learn how to operate without the essentials like anesthesia or sutures or so on and so forth. Literally, it's going back to the medieval time. And these are only the direct effects. In Sudan, for example, obviously you know what's going on there. You know that something like, I think the figures are about 3/4 of the health facilities are not operational anymore. And then that's a direct impact. But of course, then there are the indirect impacts. There is a public health impact, the destruction of water, sanitation, and such like. So public health suffers. Chronic diseases suffer. 70% of us now suffer from chronic diseases, and there's no distinction between rich and poor countries in this regard. 70% have NCDs, and of course, their treatments go by the haywire. Reproductive health, and in back to Tigray, we're suffering something like there's an epidemic going on at the moment in terms of HIV, new HIV infections born out of the rapes from the war. So that's one thing. Now, the question, I think, is not these things happening, but why? And for me, all I can think of is that this is a very cheap way of waging war. Because if you want to demoralize your opponent, if you want to terrorize them and spread fear and mayhem, what better way than to go to the underbelly of that? So that's where we are now. And what to do about it, that's another debate.
And Dr. Serafini, can you talk a little bit more from an organizational level? How does ICRC operate in conflict settings where health systems are under threat?
Yes, thanks for the question. And it goes very well in line with the previous question and some of the information that I will not necessarily repeat, but try to bring a little bit to what we do today in the ICRC when working in conflict areas. So we know that the protection of the medical mission, it's really at the origins of international humanitarian law. And we know also that international humanitarian law is that building block for humanity. Today, whomever is wounded or sick during combat has the right to treatment, and those that provide treatment need and must have specific protection. And there is where this becomes core to the ICRC, but not only core to the ICRC, but mainly core to the Red Cross and Red Crescent movement. It's part in the case of the ICRC is part of what we witness on an everyday basis. Now, what do we witness? We witness specifically those weapon barriers coming inside hospitals, extremely heavy armed. We witness those checkpoints that we should be able to cross because previous negotiations happened. But unfortunately, we are delayed with a person that needs immediate care because of interrogation to that specific person. We are also witnessing the direct destruction of infrastructures. We are also witnessing the looting of those infrastructures, the looting of those specific warehouses where the supply is being provided. All of that continues to happen. All of that continues to be witnessed not only by the ICRC, but by plenty of other organizations, and obviously the civilians that are the ones that are bearing the consequence of staff and infrastructures that cannot provide the basic care that they need in a moment where that care is obviously much needed than anyone, in any other moment. Now, what the ICRC has done, and this is already a 10-year initiative, is Healthcare in Danger Initiative. This initiative is addressing violence to patients, is addressing violence to infrastructure, is addressing violence to ambulances. What do we do? What do we try to achieve through it? We try to sensitize, but not only the health personnel on how to protect themselves, trainings on how to de-escalate violence, how to make a specific health institution or health structure more resilient to violence. We also try to work with community. Sometimes that violence comes from community. And while we have witnessed in conflict that most of it comes from the weapon barriers, in COVID we also saw how communities were one way or the other also aggressing the medical staff and institutions. So we work very much with communities, we work very much with health personnel so as to sensitize them to the situation, but also give them the tools to try to de-escalate that violence. Now, we also do believe that the specific mental health and psychosocial support that this health personnel needs is extremely important, and we try to provide that, or at least train for those that will provide that, as well as the assessment and improvement of the healthcare structures, as I said, to make them resilient to it. Another very important role of the ICRC is that specific negotiations with the ministries of health, so as to make sure that they are aware of the situation and that through policy and policy change, they are able also to influence that violence that comes directly to the health personnel, health structures, and ambulances.
Turning to you, Dr. Petra, so at the beginning of a humanitarian crisis, there's a lot of urgency, coordination is difficult, there's chaos often, but it's very important to ensure that whatever is done with communities that are impacted. Can you talk about that? What sort of strategies does your organization use to ensure communities are at the heart of responses?
Sure. Thank you for the question. And we have to, if you look at the landscape, in many locations, the Red Cross, Red Crescent is the first and only contact for people with healthcare. And in fragile contexts and conflict settings, before the international community or partners scale up their work in these settings, the local Red Cross, Red Crescent are the ones providing services. The Federation is a membership organization, and our role is to support the local Red Cross, Red Crescent in providing these services. They are present in these communities, so they're definitely trusted. They know exactly what the need is. They know the language, they know the culture. Working through their plans, our role comes in to advocate on their behalf, to support them, to influence policymakers, to bring the needed resources. And I do emphasize on the needed resources, because usually what happens in a crisis and an emergency, donors end up bringing lots of in-kind donations initially, and a lot of it is not what exactly is needed on the ground. So our role is basically what the community needs. We get that feedback from them, and then we bring it to donors and stakeholders, and we discuss the needs and discuss where we can influence and how policymakers needs to make changes. And what Mika and Mukesh mentioned earlier is we talk about protection, we talk about access, we keep talking about the same, and lately we've seen that many of this has not been respected. But we keep talking, we keep trying to influence. We do a lot of silent diplomacy to protect our volunteers and staff. We've lost this last year, we've bypassed 20 volunteers so far that have been lost between different conflicts. This is a big number when you compare it to other crises that have happened in the past. So what the Federation does and continues to do is advocate on their behalf, bring in the needed resources. And here there are two types of resources. We're talking the financial resources, but we're also talking technical human resources, and influence policy to support more their systems and strengthen them on the long term. Thank you.
Thank you. Turning to Alyoscia, I'm wondering if you can talk about the humanitarian development nexus, kind of ensuring that when humanitarian work is done, that it evolves into long-term sustainable development. What are some of the challenges around that, and strategies?
Sure. So, I mean, even in that question is a sort of slightly optimistic evolutionary assumption that things will move in a positive trajectory away from crisis and into a more stable context. And actually what we see is that things are far more cyclical than that. And oftentimes there are breakdowns of systems, whether through conflict or a combination of conflict and now accelerating climate challenges that really mean that, when we talk about a humanitarian development nexus, we're not talking about something that transitions from one point to another, but we're talking about something that is much more a series of waves hitting a shore, if you like. There's a circularity, a continuity to the types of challenges that we face. So another sort of rather quaint assumption that the aid and development industry has worked under for quite a long time is that there can be a neat handoff from humanitarian to development work, and that has rarely been borne out in practice. Oftentimes what we find is that there are very, very different funding constraints. The level of investment per capita is completely different in a humanitarian funding. It's much higher in a humanitarian funding setting than it is in a development funding setting. So there tends to be a very sharp shock that takes place when you hand off from a a humanitarian-funded intervention to a development one. And that is a shock that takes place even if there is a continuity of funding. So what do we do about that? I think there's tons of different strategies that we as a humanitarian organization that is interested in applying developmental methodologies have used, as have others. I mean, this is a rich and kind of fertile landscape where a lot of organizations are investing and are trying to make the best out of what is an artificial divide that is itself handed down by how we chop up investments, really, how we access funding as a community. Some of the I think some of the success strategies really are about rooting more developmental methodologies much earlier in interventions that we carry out in a humanitarian context. They're about leveraging and investing in the systems that exist. And by systems, I don't necessarily just mean the formal health system. I mean those systems through which people survive, people are able to access however scant services that might exist, the way that people access markets and the way people access services and supplies. And I think spending time understanding that and leveraging that and leaning into the dynamics that are at play in any community in which we're intervening and which we're trying to help people is fundamental to being able to build something that's a little bit more sustainable with the resources that we have available. I think there's some really interesting innovative financing ideas that we're now looking at in the kind of nexus space. So looking at the different roles that different types of investment can play. So, for example, big bet philanthropy is really, really useful to experiment with novel interventions, whether that's new ways of delivering an existing service or a new service altogether. I think there's an interesting opportunity for humanitarian agencies to de-risk some of that by actually being able to leverage our ability to access quite remote and difficult areas. And I think there's also huge scope for the MDBs and development donors to really lean into different ways of working with the likes of us to think about how we can leverage our access and our relationships in conflict impacted communities to actually lead into more sustainable engagement. There's much more I could say, but I can see the clock counting down, so I'll stop.
Thank you. I'm just going to open a question to the panel, and it's clear that the international community and systems are failing humanitarian actors. I know this is a very long discussion, but I'm wondering if you could give a few comments on the ways in which it's failing and what you'd like to see out of the international community from anyone who would like to respond to that.
Sorry, failing on health or failing?
Failing on health, in particular,
Well, I think from the health perspective, I would say there is a problem of paradigms. And I speak as a former director for emergencies for WHO. You know, we're taught about health systems and how we must work for universal health coverage. And this is a very systematic process, almost pyramidal in terms of the way a well-organized, stable health system operates. But considering that so many countries are now in chaos and confusion, and crisis is a way of life for millions of people. I think Tedros was saying the other day that something like 3 billion people are not getting any health care, never mind universal health coverage. So what that means is that we haven't yet figured out how to apply the systematic application of healthcare technologies and systems to the chaotic situations we find in conflicts and crisis. And this is because we are not able to somehow adapt that to the fact that issues are not systematically done. Now, I have one wish, and here I speak from my former experience as Undersecretary General at the IFRC, and that is I dream of a world where actually everyone in the world is trained in first aid, which is what my Red Cross friends here are experts in. And the idea is, because, we're all moved by the blood and gore that you see on TV. But the fact of the matter is that 90% of the conditions are self-treatable, or even in crisis circumstances. And of course, you had a panel on carers and self-care, and that's an important element. Imagine if you could put first aid kits in the hands of every single household. And if you're in a crisis situation like Afghanistan or somewhere, then I think sort of mass distribution of first aid kits would go a lot. And if you look into the efficacy of first aid things, they would actually have a significant contribution to make in terms of reduced preventable and curative methodology. That's just one idea. There are many others, like technology and so on and so forth. And if you want to talk about the wider humanitarian system, then I'll come back to that if you've still got time.
Dr. Serafini, I'm wondering if you can talk about there's huge challenges in patients with non-communicable diseases in humanitarian settings, and kind of access to services around that are quite challenging.
Indeed. There is where the triangulation again, when it comes to conflict, when it comes to access to healthcare, and this idea of having a disease that you're going to carry all your life. When you are in conflict, and that, again, by treating patients, you realize that your access will be hampered, and your treatment might not get to that place. So there is where the big problems when importation, embargoes, you are at a higher stress than usual, and you know that you will have to have follow-ups. So what the ICRC realizes is that this idea of the chronicity of diseases during conflict brings disruption, and that stability that a patient needs to be able to is disrupted with conflict. Now, how do we do to try to bring that stability back? One is acknowledging that stability will not be exactly the same as before. And there is where we try to bring, again, in the phase or in those countries that are prone to conflict, there is where we start negotiating with the Ministry of Health, but also collaborating with that specific national society so as to have that contingency plan that will be able to assure that during a certain period of time that continuity at least of supply of medicines of those NCDs that are prevalent and that will have very negative consequences if not treated: cardiovascular diseases, asthma, epilepsy, and diabetes. Once that preparatory phase is negotiated, done, and put in place with ministries of health and obviously with our colleagues in national societies, then it's the moment that conflict erupts, is how that preparedness responds. And there is where we are very attentive to see if we have to continue that support, or if we need, or they need only indirect support, either with importation through the ICRC diplomatical channels of that supply, or direct human resources or whatever might be needed to top up that service and maintain those patients that are able to access the services at least stable in their diseases.
Dr. Petra, humanitarian crises are obviously very traumatic for the individuals going through them. What does your organization do to kind of integrate psychosocial support into your responses?
As you mentioned, the trauma caused by conflicts and compounded crises touches all levels of ages: elderly, children, women, all the vulnerable populations in the communities. MHPSS and Mika and I, we work together on creating an MHPSS hub for the Red Cross Red Crescent network. We have, as a federation, an MHPSS center that is now celebrating 20 years. And that center has provided MHPSS services to the whole network. And in every emergency response, one of our core elements and plan in the emergency response is to create MHPSS support and programs and tools to help within the response. Also, in the response, we always create what we call safe spaces and children-friendly spaces, support on the mental health, and to provide psychosocial support. The whole response has a main pillar into it that revolves. And we talk now most recently about the Gaza response, and we see that the Palestinian Red Crescent is providing major mental health and psychosocial support to people that have moved multiple times and they're now residing in tents, and the impact of the loss on kids losing their parents and the loss of parents losing their children. And so as we speak, in a major crisis, the Palestinian Red Crescent is probably one of the only organizations on the ground that is providing MHPSS. And we continue to support that because we believe it is a core element of connection between the people and the Red Cross. And because of the trust that is there, they feel the safety and the security to come forward and share and receive the care needed. Thank you.
Thank you. Alyoscia, in humanitarian responses, there's a crucial need to kind of work with governments to coordinate the response. Can you talk about kind of what goes into kind of an effective partnership with governments?
Sure. So, I mean, it really obviously depends on the context and the degree to which the government in question is a party or not to conflict, has control or not over the territories in which we're trying to, or they're trying to bring healthcare to the populace. So different strategies for different contexts. Obviously, as with any partnership, as with any engagement, it's around mutual respect. It's about understanding the other. It's about understanding the incentives, what drives particular agenda in a particular context. So, we're very, very clear that our role is not in any way to substitute for government, but in certain contexts, we can play a useful role to actually reach difficult to access areas. We're doing this right now with a vaccination program spanning 4 countries, covering 150 plus communities that were deemed very, very difficult to access. And by patiently working with embedded kind of access negotiators and with an understanding of the local community dynamics, we're able to help bring vaccinations to previously deemed impossible to reach areas in ways that are lined up with international norms and government policies, but in a way that is respectful of the dynamics in the context. So, different things, different countries, different contexts. But I think for me, mutual respect and an understanding of what each party is trying to get out of the relationship is absolutely fundamental.
Thank you. Dr. Mukesh, you've been vocal about kind of changes in the humanitarian system and also in particular humanitarian organizations. You wrote an opinion piece in December calling for structural changes in the ICRC. Can you talk about that?
Well, I think that's specific to ICRC or Red Cross nerds like us. But can I generalize from that to talking about the humanitarian system more generally? 6 points, but I know the clock is ticking. The first issue is that the whole humanitarian idea, as is currently conceptualized, is in trouble. Not humanitarian values, but this humanitarian values that are instinct to all of us are not the same thing as how humanitarianism is practiced in reality. And the number one problem is the concept of humanitarian principles, particularly the concept of neutrality and the concept of independence. Now, neutrality, we all understand it and it's good, but ordinary public doesn't understand it. And the dictionary meaning of the word neutral is not a good one. And also words change meaning as time passes. Today we live in the age of solidarity, not in the age of staying at the sidelines, which is what the definition of neutrality is in the public mind. I'm not saying that's a definition as defined by the humanitarians. So independence, we don't have any. I mean, how can an organization claim to be independent when it's largely funded by governments and, or foundations or whoever, and who pays the piper calls the tune. So nothing wrong to be funded by all these people, but, don't call yourself independent when you are not. And I think the public knows that. And everyone has an agenda, and this lack of trust that is coming in. Humanitarians have got to address this, and this is a problem. The second problem I find is that humanitarians have a minimizing mindset, and that's come out of lack of funding. So, when I trained in medicine and surgery and actual practicing, I would operate in the same way, in good times and bad times, in bad days and good days. But what humanitarians do, because they have requirements, so many liters you can survive on, so many people you can stuff into a refugee tent. So you have a minimizing mindset of what is the least you can get away with in order to save humanity. Don't blame them. It is a consequence of, unfortunately, the world we operate in. The problem is then when your minimizing mindset goes into the humanitarian DNA, then you can just think what the implications are of that down the line. And how to deal with that, but that's another debate. Third is I'm very concerned in the current international humanitarian system, there's a lot of risk transfer going on. Look at the stats about the number of people who are killed. Most of them are local people, because most humanitarian workers are local people. But I think there's a risk averseness in international organizations, and they're transferring risks to locals, and this is not adequately accounted for. Fourthly, organizational size. When we had the financial crisis, we talked about banks too big to be allowed to fail. Well, I think, and I'm going to be shot down for this, some humanitarian organizations are too big to succeed. Because, just think about it. And I've worked in all the world's biggest organizations, I can tell you, from the Red Cross system to the UN and in between. Now, the point is that when you become big, there are a lot of transactional costs within the system. And that, I think, leads to the problem that the organization becomes self-fulfilling, internal hygiene occupies a lot of space and time. And with that also goes the ego of international organizations in particular, who are almost like superstars in the way they perform and behave, and they're posturing on Twitter who they met, who they didn't meet, not on substance very often, though there are exceptions to this, I hasten to add, including Tedros is an exception. Finally, perverse incentives. And that is, the whole humanitarian system is funded perversely. The more aid you give, the more money you might receive. Therefore, the more cut you can take for your own organizational maintenance, and that means the answer to everything is aid. And you can see where that is going to lead you. So my suggestion is that we need to revisit the humanitarian idea, and that includes the health dimensions of the humanitarian problem, and reconceptualize the whole thing, because otherwise I think we are, and I won't use the bad word I was going to use just now.
Thank you. So we are we're past time, but I do want to give you, the organizations, a chance to respond if you'd like to. What does anyone want to? Okay.
Sure, you can go. I think your question about, I'll go back to your question about what needs to be done. Do not put the failure of the political system on the humanitarian system. This is what needs to be done. Yes, the humanitarian system needs to refine itself. Yes, we are at a crossroad. A lot of the things that we built in the past are being questioned or at stake. But at the fundamental core of all of this is the failure of the political system for years and years. The policymakers that we voted for, each one in our respective countries, are contributing today to what we're seeing on the humanitarian side. We're asking the humanitarian system to come fix crises that are the result of the political failure. Afghanistan, Gaza, Sudan, you name it, Lebanon, Yemen, Syria. All of these are political crises that suddenly become the responsibility of the humanitarian sector to fix and bear the shoulder of its consequences. Yes, the humanitarian sector does require, I mean, I joined recently the humanitarian sector. I came from a completely different world. But the humanitarian sector is being asked today to deliver on 130 conflicts globally. These are just conflicts. To respond to natural disasters, to respond to climate change, to respond to everything, all types of emergencies, a pandemic, all of that, without any hand from the other side on the political side. And we're not going to work politics. We're going to be supporting where the needs are. And organizations grow in size because the needs grow. If the needs are less, organizations will not grow in size. The needs are growing, and the organizations are responding more and more. We would love to see a system, for example, in Afghanistan, where there is no sanctions and the system operates on its own without the need to put the burden on the humanitarian sector to become suddenly the formal system of the country, right? Same in Syria, same in other settings in conflict in Yemen. So it is important that we put the context of why is the humanitarian sector, where is it today? Why has it stretched so much beyond its own mandate? I do agree that in many organizations, they've gone beyond their mandates. But the reason it's happening is because they're responding to a certain need and a certain context and a certain situation. Thank you.
Thank you all. Sorry, we've run out of time, but please join in thanking our panelists.